Okay, well, just to keep us on time, we can go ahead and get started here. As I mentioned, my name is Caroline Teeple. I'm a sociologist and qualitative methodologist in the qualitative and mixed methods core at Accords. And I'm very happy to be here today and to present all of these wonderful posters we have here. So first up, we have Brian Garner, who is from RTI International, and he is going to be presenting about assessing innovation practice fit, a new measure. So
thanks so much. I can go off of that slide, but in some of the presentations yesterday, they were allowing us to share our screen. Could I do that?
Sure, I don't see why not. I don't think I'm in charge of the tech part of it, but I think
it looks like it's going to let me. Okay, thank you. I think it'll be helpful for this. Oops, I can find the right file though. Sorry, guys. Now I'm clicking too fast and it won't keep up. There we go. All right, sorry about that. So hi everyone, Brian Garner. I'm from RTI International. As Caroline said, I'm a senior implementation research scientist there. And I'm really appreciative of the opportunity to tell you all about a new measure that my colleagues and I developed as part of a project funded by the National Institute on Drug Abuse and is called the Substance Treatment Strategies for HIV Care Project. The overarching goal of this project is to help improve the integration of substance use disorder treatment interventions within HIV service settings. And in the amount of time I have, I can't kind of go into all the details, but for any folks who might have attended a session I did yesterday on what we called a new method called the Stakeholder Engaged Real-Time Delphi, it was as part of that methodology that we collected the data using this new fit measure. As far as more background, the impetus for the development of this measure really came out of some of the work that was put forward about 25 years ago by Klein and Sora as part of their theory of implementation effectiveness, which really came out of more organizations for technology-based innovations, but that Brian Weiner and colleagues have put forward for complex psychosocial interventions too. And as part of their theory, one of the keys is innovation values fit, the fit between the innovation and the values of the users. But when applying this to organizations that will make decisions about what practices they might decide to adopt and prepare for and implement, it's not so much about the values as it is the fit between the innovation and the practice setting. And in contrast to other constructs that are part of that theory, such as implementation climate, which is really important. And there are a number of widely used measures. There aren't any really widely just kind of tried and true measures of fit. And in fact, the reason I kind of wanted to share my screen was, here's a 2020 article talking about assessing fit as an overlooked step of the implementation process. And I agree. I think a lot of times what happens is folks will get sent to a training, possibly like the whole organization's staff, and then afterwards are asked about the extent to which it fits or is acceptable, feasible, appropriate. And if they do find out that it's not, it might be sort of the case of, well, why did you send everybody to the training first? So what we've done in this project, it was part of a large-scale national stakeholder engaged real-time Delphi where we had over 250 HIV service organizations have one of their representatives participate. As part of their participation, they learned about 9 different evidence-based interventions for substance use disorders. And when they learned about them in a standard way where we would talk about the staffing requirements needed for each of these interventions, what substances they've been effective for, how much training is typically required to train a staff, and the amount of time and other resources to deliver them, trying to provide them with some standardized information so that they could make a good judgment on the extent to which it was a good fit for their setting at this point in time. And the criteria upon which we asked them was that really makes up this 6-item measure are shown there in the legend of the figure. We asked them about the extent to which the practice in question was fundable, that they would be able to have the funding to train or hire or train a staff member to provide this to clients in need. If it was implementable, that if the client, if a staff member was trained, that they would actually be able to have the time and other resources necessary to implement it with clients over time. Whether it was retainable. We know staff turnover is a big problem, and so we asked them to the extent that they thought they might be able to retain a staff member trained for at least a year, so there could be at least some return on investment. The extent to which it was scalable, the extent to which if needs increased or decreased, that they would be able to train more staff, and sustainable in the sense that if a staff member did quit, we know sometimes when there's staff turnover, the implementation effort might die with them depending on how many staff were trained, but could they sustain it by training more staff? And then finally, to the extent that they felt it was timely, that it was an innovation that they needed and that they could try to do at this time. And to kind of just to wrap up the results of this, I mean, what you can see here in this figure is that we were able to use this 6-item index measure to rank order these 9 different evidence-based interventions. And it's important to look at both the absolute fit on this scale, with very few of them being above the midpoint. Only motivational interviewing was above it. And so it seems like it's the best fit for these HIV service organizations, where the others may not be at this point in time a good fit. And we're able to test differences between the different practices. We've been able to look at how different characteristics about the organizations predict their score on these. And so we're using this, this method to try to move forward with promoting motivational interviewing. And we currently just wrapped up using this fit measure to talk about which implementation strategies might be the best fit for the AIDS education and training centers to use with HIV service organizations. So anyway, it's a new measure. It's only 6 items. If people are interested in learning more about it, please email me and I'd be happy to share more information with you. So thanks so much.
Great, thank you, Brian. That was really interesting. We have a couple of minutes for questions before we move on to our next speaker.
This is Natalie. Just a question. Are you intending on evaluating this measures and other outcomes? Do you have the capacity to do that, to see how it transfers?
We'll be able to look at its predictive validity as part of the second aim of the project. Yeah, and we're going to be doing a large scale cluster, a randomized trial of the organizations to try to test different strategies to do it. So it's very possible that their reports on these could moderate the effectiveness of those strategies. The external facilitation is the strategy that we're testing.
It looks like we have a question in the chat for you, Brian.
Oh, okay. Let me look. We have. So it's not intended to be a scale in the sense that the items would necessarily hang together. It's more of an index. Although, because they did tend to hang together really well, surprisingly so, even though that wasn't our intent. And I believe that almost all of them had coefficient alphas that were 0.9 or higher. So again, it wasn't really intended to be a scale. It's intended to be an index, but it's operating a little bit like a scale too, because they are hard, like they're all sort of low for this particular setting.
I guess you sort of hinted at this already, but I wonder if you could just comment on where you're going next with this measure.
Yeah, no, absolutely. I'll say more about what we did. I mean, again, we were trying to say, well, if these are the most promising treatments for integration into these settings, then what are the different strategies we could use? And we all know about the 73 strategy compilation that the project's guiding coalition of stakeholders, which is made up of folks that were relevant to this. We landed on 10. We picked 3 from the preparation phase, 4 from the implementation. 3 for the exploration phase, 4 for the implementation phase, and 3 for the implementation phase. And we're trying to get a sense of what capacity these AIDS education and training centers have to provide these strategies to HIV service organizations. And so we're looking at the fit of these strategies for them. So that's what we're doing now. And we just wrapped it up yesterday, actually. So I'm looking forward to seeing what our results are. We'll have a similar graph as to what I showed you here, but for strategies and for technology transfer centers.
Great. Well, we'll all look forward to hearing what happens next.
Yeah.
Okay, well, just to keep us on time, we're going to head into our next presentation with Natalie Huguet, and she's going to be presenting about precision implementation, developing and validating predictive models of information technology tool adoption. And she's coming from Oregon Health and Science University.
Thank you. Hi. If you could, perfect. So, hi, I'm Natalie, as Caroline said. I'm in the faculty in the Department of Family Medicine at OHSU, and I'm representing the Bridge C2 Center, which is a NCI implementation science center. And as part of the center, we're conducting research pilots and also methods pilots to advance implementation science. And so this is one of those methods pilot. So there's a gap in implementation science in the lack of methods to precisely assess which practices will benefit most from a particular implementation science strategy, or how much support a practice might need, or if some practices can improve an evidence-based intervention on their own or need more support. So what we wanted to know is whether or not we can predict how much support a practice would need, or how difficult a practice, how much struggle and challenges a practice would have in adopting an HIT intervention, and whether we could use EHR-based data to do this prediction. So the aim of the study specifically is to develop and validate a predictive model that estimates the likelihood of adoption and sustainability of an EHR-based tool using machine learning methods. So we extracted EHR data from 351 community health centers. They all have a single instance of Epic, so they're all on the same EHR system. And the tool in this case is an insurance support tool. So that's not a clinical tool, and it is designed to assist eligibility specialists, which is a special position within community health centers, to track and document the number of patients that receive health insurance assistance. So eligibility specialists will assist patients to get insurance. And so these positions are funded by HRSA. And HRSA has a requirement that the CHCs report the number of persons they assisted. So this tool is specifically designed to help them report, do the reporting, and also track and document their assistance. So here adoption is measured as any touches of the tool. So if a person uses it once or 10 times, it's adoption. And then sustainability is using the tool at least 4 months prior to the end of the study period, which in this case is 24 months post the go live date. And then we used every EHR variables we could extract. There's about 27 different indicators, and they're not all in this table. Obviously, that would be too many. And that includes like encounter type data, patient panel characteristics, clinic geographic data. And so we put all of this in the models. So we developed a model that had 70% of the sample and then validated it into 30% of the sample using lasso penalized logistic regression modeling for the machine learning approach. And so what we found is overall, the EHR had really good predictive performance for adoption and sustainability. And you my slide is blurry on the video, so maybe you have blurry videos as well, but for adoption, it's above, let's see if I can get a better version here. Hold on 1 second. The model fit is above 78%, and then for sustainability, it's around 80%. So in other words, it's pretty strong, but then there were very few predictors that were significant. So we had a lot of predictors, but really only for adoption, years of EHR, so years being in EHR, and that makes sense. The total number of visits, and then the percent that were of those visits that were for ambulatory care were predictive of adoption. And then for sustainability, only the total number of visits. So overall, the total number of visits, which is kind of more or less a proxy of the size of the clinic, was the most important factors extracted from the EHR that predicted both adoption and sustainability of this non-clinical tool. So what we could conclude from here is that, yes, we can use the EHR to do a predictive model for adoption and sustainability. It has great performance in terms of statistical fit, but that very few predictors out of this really long list of indicators were associated, were predictive of either adoption or sustainability. So our next step is to use the same model for a clinical tool and see how that's different. We also intend to maybe include this EHR proficiency score. We're still trying to figure out how we're gonna get that in the model. So that's where we are with this project. I'll take any questions. Thank you.
I guess one question, I think this is really interesting, and definitely do a lot of kind of, I've done some kind of HR tool implementation. It'd be nice to have a sense of like what my success rate was going to look like and what factors would help drive that. Are any of, it looks like looking at these characteristics, these are all based on the implementation setting and none of these are based on the EHR tool itself. Is that correct?
Yes. So, well, I mean, the EHR tool in this case, what you could get from it, you know, the different functionalities, and we did struggle about how do we identify the different functionalities that may be for which you would have a better prediction, and then also the part, like, you know, the idea was like, could we use just the EHR data and predict who's going to be adopting, so you could kind of like, you know, direct your budgeting and figure out what strategies. And then the one thing we were also discovering as we were doing this is like, why, you know, why is the tool used by who and how, which differ. Like this tool could be used only once, or some people would use it every time. And so this section it's still, you know, the overall conclusion is that yes, you could use the EHR to do some prediction, and clearly practice size does matter, but you still need to go and talk with stakeholders to just understand how they use it. And so that still is that part. So there's, you know, you can't, so yeah, so the tool functionality by itself, we can't really extract that. You can extract the number of times someone touched a little functionality, but you can't extract why they touched it, when they touched it. So that's a limitation.
And I guess it just would be really interesting to see kind of how this model and how prediction changes across different types of tools. So cool that you're doing a clinical tool next, and even like kind of, it'd be really interesting to see how different types of clinical tools might have different profiles. And so cool kind of groundwork. And I'd love to see kind of more of that kind of, yeah, by tool type would be really interesting.
Yeah, I agree.
Great. Brian, did you have a question also? Oh, okay. You were unmuted. That's all. That's why I was asking. Okay. Well, wonderful. I think we can head into our third presentation for the session. So next we have John Watson from here at the University of Colorado, and he's going to be telling us about controller medications and serious early childhood lower respiratory tract illnesses.
All right, thanks for your attention. And like Caroline mentioned, I'm Jay Watson. I'm one of the, actually a pediatric hospital medicine fellow here at the University of Colorado. and work mainly at Children's Hospital, Colorado. I don't know that this study is, to be honest, a perfect fit for this kind of measures and methods talk, but I do think we did some interesting methods. And so I'll try to kind of highlight that more heavily as I talk through this presentation. And so we looked at controller medication use in serious early childhood lower respiratory tract infections for this study. And for background, this project was born from a really tricky clinical question that we struggle with a lot in practice of when to prescribe controller medicines, primarily referring to inhaled corticosteroids in our patients less than 2 years old presenting with recurrent lower respiratory tract infections. And by that, we primarily mean bronchiolitis. That's the most common thing we see. And as some of you may know, controller medications have proven benefit in decreasing exacerbations in older children with asthma, but also have demonstrated benefit in children with recurrent wheeze. However, studies looking at controller medicines, even in the preschool age group, are mostly looking at older populations, often 2 to 5 year olds, and have not really shown a benefit to controllers prescribed after lower respiratory tract infections. So we were kind of interested in diving into that gray area where these overlap, as it's really hard to differentiate, on one hand, early onset asthma, and on the other hand, bronchiolitis. And so the decision of when to prescribe these controller medications ends up really being a judgment call without really a clear sense of when we're making the right decision and when we're making the wrong decision and what factors should guide that. So in an attempt to provide some clarity to that, our objective was to assess the association between time on controller medications and either emergency department or inpatient visits for LRTI or asthma in children less than 2 years old after their first LRTI. And then for methods, and again, I'll focus a little more here since that's kind of the category of talks that we're in this group. We performed a retrospective cohort study using administrative claims data from the Colorado All Payers Claims Database. We excluded children with complex conditions, asthma, or controller use prior to their first LRTI. Our primary exposure variable was a time-dependent indicator for presence of a prescription for the controller medication. And our primary outcome was a count of either emergency department or inpatient visits for a diagnosis of LRTI or asthma using ICD-9 or 10 codes there. And our analysis was a Poisson regression accounting for correlation within subjects for person time data. And now in my poster, if you'll draw your attention up to the top of the second column, and I know it's probably a little hard to see over Zoom, but figure 1 provides the timeline representation of what we actually did for this analysis. And I think where our methods get a little interesting is that rather than looking at this data on a patient or subject level. So for instance, saying, did a patient, were they on a controller at any time would be a way we could have approached it at a patient or a subject level. We actually tried to get a little more nuanced and try to really get a more accurate representation of when this controller medicine could have been helpful. So what we did, like I mentioned, our primary exposure variable was actually a time-dependent indicator of a presence of prescription. And so specifically when a patient, our administrative claims data showed us when a patient filled a prescription and how long that prescription was. And so the first timeline kind of shows this. We started them, as you can kind of see looking across that top, they were just walking through a practice patient. They would be in non-exposed time until they got their first prescription. And then if they got a prescription, we gave them a 7-day washout period when presumably that controller medication hadn't really started having effect yet. And then after that 7-day washout period, we would consider them in exposed time or on a controller. And then whenever that prescription would run out, we would consider them back in non-exposed time. Now, if they were to refill that prescription, then they would continue in exposed time. So that really allowed us to look at what time were these patients actually on controller and what happened then versus what time were they not. And so the second line, you can see how if they had an inpatient visit at that first tick, that would map into non-exposed time or off controller time. And then that ED visit, that second tick that you see there along the timeline, would have mapped into exposed time and counted under exposed time. And so I think that since this is kind of a methods group, I thought that was an interesting way to approach it. And it was kind of a way to, when thinking about kind of doing retrospective data analysis, to still kind of get down to more nuance than subject or patient level. And then to get into our results, and for sake of time, table 1 shows our cohort characteristics. I'll really quickly summarize that as to say those who were at risk, who had characteristics that map to being at risk for asthma, were the ones who were more likely to be put on controller medications, more likely to have time on controller. And then table 2 is actually our results from our Poisson regression. And if you look, the first line is our controller meds, so our primary variable there. And initially we see a crude rate ratio of 1.51, indicating that those on controller medications were actually more likely to have an ED or inpatient visit. Now that was to be expected because that's definitely a higher risk population. They're more likely to come in with lower respiratory or asthma visits. So we weren't surprised by that. We were pleased that with our adjusting for our other variables, we saw that drop, indicating I think we were getting a good signal here, and our analysis was working. And so you see our adjusted rate ratio of 0.77 with a 95% confidence interval of 0.57 to 1.05. So still not a significant result, but I do think the drop at least shows that we were getting a signal. And so that brings us to our conclusions that in children under 2 with LRTIs, we more often prescribe these controllers in patients with asthma risk factors, that concurrent prescription for controllers was not statistically associated with ED or inpatient respiratory visits in children less than 2. And I think this lack of association could indicate a need for increased prescription stewardship. And in a very pragmatic sense, at the rate that providers from 2009 to 2017 were prescribing these, we actually don't see any statistically significant benefit in preventing these visits. This did have some serious limitations. We potentially incompletely controlled for that indication bias, like I mentioned, with these patients being a higher risk population to begin with, who would get started on controllers. Our indicator of time on controller, even though I think it's more elegant than subject level data, it still has its limitations of we have no guarantee that the patients were actually taking those medicines when they filled the prescription. And then our claims data was imperfect. So we did have a lot of missing data in that, and we were relying on ICD 9 and 10 codes as opposed to kind of a prospective study that could get more valid information or more valid data. And so I think this would be an interesting area for future prospective studies. And I do think even based on the data we have here, there's a good argument to be made for increased thoughtfulness in prescribing these controllers in this age group. And that's what I have. I'd love any questions if we have time.
Great, thanks, Jay. Yeah, we have a few minutes for questions.
I guess I'm trying to get the non-exposed, exposed. The exposure is the control of medication. I was just thinking, how do you, because there's a lot of based on there's a lot of people who have at least 3 events where they're gonna be hospitalized or ED visit. And so, but your outcome here combines any time, right? It doesn't matter if it's before, after. I was just thinking, can you measure, like I was thinking a difference of difference, I guess. Do you measure if the rate of, are those rate ratios? Did I miss something? Basically I'm like, is there a measure of the rate of being hospitalized prior to getting the control meds versus the rates of being hospitalized after getting the control meds to compare? And is that a rate ratio you have
Yeah.
there? You said R?
Table
Okay.
2 is rate ratios, exactly. So we are comparing those rates between time off versus time on, and it was a very unbalanced sample, which was part of the challenge in analyzing it, because we have it's pretty rare event to be overall. I mean, to be prescribed controllers in this age group. It's such a common diagnosis of bronchiolitis and LRTIs that it actually ends up being absolutely fairly common, but relatively most of our patients with recurrent LRTIs don't get on controller medication. So yeah, we're definitely looking at the rate ratios comparatively here. So our prediction would be that if you're on a controller, you're once adjusting for all of these other variables, there's a 0.77 relative rate of having an ED admission or inpatient admission. But the challenging thing there is the 95% confidence interval did cross 1. So I don't want the takeaway to be that that we've reduced admissions, because I don't think that's honest with our confidence interval. Does that sort of answer what you're asking? Sorry.
Yeah, it makes you wonder which variable in there is when you adjust is leading to that downward trend.
Yeah. And I think the biggest one was actually adjusting for family history of asthma. We know that's a huge predictor of a future asthma diagnosis in these patients. And so I think without being able to say this definitively, I think essentially the patients who have early asthma, this has a benefit for, and the patients who don't have early asthma, who are just coming in with recurrent bronchiolitis, we don't see a benefit here. And so essentially, by controlling for these risk factors for asthma, we're able to kind of correct for that higher risk asthma population. But I still think we're not quite overcoming that completely. And whether that's because there's such a large percentage who aren't going to go on to develop asthma that's diluting it out and making that confidence interval cross 1, or whether we're missing some variables we're controlling for and are incompletely controlling for that indication bias, I think is really hard to say, and I definitely a limitation of this work.
Wonderful. Thank you all to our speakers today. I'll just make a few closing remarks before we wrap up here. I think all 3 of the presentations today really highlight the importance of being able to do some amount of prediction and pragmatic research. So, it's good to develop new approaches for things and develop new innovations, but it's also important to learn about when something is going to be effective, whether that's a particular approach to care or a particular treatment or a particular tool. So I think all 3 of the presentations really highlighted different ways that we go about assessing that and measuring when something is going to work. So I think that's a really important contribution, and I really appreciate hearing from everyone today. We do have an extra minute here, so if there are any final questions or thoughts people would like to share, please feel free to do so.
Just thanks for moderating and hosting this.
My pleasure.
Thank
Yes,
you.
thank you.
Thanks, everyone.
Take care, everyone.